joined now by two people. We're going to hear from Naomi Davies, who's an advanced nurse practitioner and is also in the School of Nursing and Midwifery in University of Galway. Thank you. Naomi has worked for 22 years in emergency departments between the UK and Ireland, the last 16 in the emergency department in Galway. She became a registered advanced nurse practitioner and registered nurse prescriber in 2013. She commenced a new role in the School of Nursing in September 22 as a clinical tutor. And this is the first shared appointment for advanced nurse practitioners in Galway, working both clinically and in the university. Naomi Davies, you're most welcome to the podium. Thank you.
Thank you very much for inviting me to talk today. As I said, I'm an advanced nurse practitioner here in Galway University Hospital, and I've just started my role as a clinical tutor in the School of Nursing. So when we talk about shifting of tasks in healthcare, I just want to see if I can put this to work. Oh, sorry, okay. We'll go back. So shifting of tasks in healthcare, we want to ensure that a task is undertaken by the most appropriate person at the most appropriate time. And the benefits of this are well documented. I moved back from working in the UK in 2006, and at that stage, at ward level, nurses weren't doing some of these extra roles. They weren't, doing IV cannulation. They weren't giving first dose antibiotics. So there were a lot of delays to healthcare. Patients weren't receiving antibiotics when they should have done. We weren't doing ECGs on patients who were experiencing chest pain. Patients were waiting hours for an intern to come and recite cannula. So clearly there was a need there that needed to be addressed. So nurses started to undertake some of these additional tasks. And the Haddington Road Agreement then in 2016, which was an agreement between the government and the unions, kind of cemented this in our practice. So nurses then were taking on these roles and were being remunerated for this as well. There was a little bit of negativity still around this because obviously we're all really busy and we're to the pin of our collar and we're taking on more roles with very little reward. And I think for nurses, for this to work, that there has to be a transfer of tasks to our healthcare support workers as well. There is some resistance still on the wards to nurses taking on the role of IV cannulation, for example. So we, in GUH this year, we set up a team of assessors to help support nurses at the bedside to ensure that they became competent in the role. So that's working really well. Just one reported issue that's come to light recently is some medical interns are now saying that IV cannulation is not actually part of their role anymore. And we'll quote the Haddington Road Agreement back to the nurse saying that's your job, but you're being paid for it now. I think it's important to ensure that we all keep working together and we all keep our skills up to date, and maybe that we move from the sharing of tasks more to, or from transfer of tasks to sharing of tasks. But if we are sharing tasks, that has to also be supported by policy. So there are challenges. Our emergence of some new roles also in Irish healthcare, and physician's assistants has been mentioned already today. There is an education programme in the RCSI, and they're now being employed in the private sector in Ireland, and I'm sure they'll be coming to our public sector as well. They've been in the US for quite a few years, and studies there have shown them to provide equivalent levels of care and as doctors, and also increased throughput and productivity. I suppose the role of the advanced nurse practitioner we're a bit more familiar with here in Ireland. Again, we're a little bit late to the party. The first advanced nurse practitioner was in the US in the 1960s. We had our first one in Ireland registered in 2001 in St. James's. And then the first one in Galway then was Helen Burke in diabetes in 2009. And advanced nurse practitioners, they have been shown to improve patient outcomes, increase patient satisfaction and reduce waiting times. So we know that it is a good model of care, it does work. I commenced my role in 2013 in ED. I was very lucky at the time to have the support of a very motivated clinical supervisor to help me get me across the line, which was great. When I started the role, there was a lot of ambiguity around it. Even the term is kind of a a funny term, advanced nurse practitioner. One of the first patients that I met, he was a farmer from Connemara. Paddy was his name, and I introduced myself. Hi, Paddy, my name is Naomi, and I'm an advanced nurse practitioner. And he looked at me like I had 10 heads. He's like, your name is what, and what you do? So he goes, can you look after my hand? I was like, I can. So that's all that he was cared about, that there was somebody there that could provide a timely service for him. So off he went to X-ray anyway, and then a little while later, I could hear him out in the corridor, and he was going, I'm looking for that nurse. I think her name is Naomi. She's one of those high-maintenance nurses. So, there was a roar of laughter out on the corridor course from my colleague, and she thought that was a very apt name for us. Maybe he hit the nail on the head. Yeah, I think we are providing a good service in the emergency department and throughout the hospital. There have been challenges to the role. There are challenges to those giving up the task as well as those taking on the new task. For example, in the emergency department, there's a concern that some of the NCHDs aren't getting exposure to looking after patients with minor injuries, and so they're becoming de-skilled. And that's not what we're here for. We're here to provide a timely service to the patients. And we're not here to replace NCHDs or to de-skill them. We want to work together to provide a better service for the patients. And definitely there's shared knowledge on both sides, and we work alongside each other to try and overcome that. Another frequently reported barrier, and we had a lot of talk today about teamwork, but a barrier to the advanced nurse practitioner role has been team factors. The A&P no longer really feels part of the nursing team, and they're not part of the medical teams. There has been issues of isolation there. But again, I think if each team member has a clearly defined role and reporting mechanisms and structures in place, then that will definitely help with that. And also to ensure success, I think it's very important that there's buy-in, particularly from the team leader, also from hospital management. I think the hospital management at UH have been really supportive of the role of the A&P, and also there needs to be a willing and able candidate to undertake the role. So future goals. The Department of Health in March this year published the expert review on nursing and midwifery in Ireland. And one of those, thank you, somebody just made the screen bigger here for me. One of the goals was, one of the recommendations was that graduate entry nursing be part of that, and Dimon is going to be talking about that later on this afternoon. They also recommended that there be more joint clinical appointments between academia and the clinical setting. So I said I was the first A&P joint appointment. I've literally just started, so they've thrown me in at the deep end here. Thanks, Martin, for asking me to do this today. But I'm actually honoured, and I really hope that the role will work, and there'll be a lot more in the future. It's a great opportunity to ensure more collaboration between the School of Nursing and the clinical setting, to harness the expertise from both sides. There's a lot more work to do. One exciting opportunity is that hopefully we might get the nurse prescribing of ionisation radiation into the School of Nursing as part of the Master's programme. That's in Dublin and Cork, but we want to bring it to Galway too. I suppose I just want to finish up there to say that our ultimate goal is to provide a timely, safe care delivered by competent practitioners, be they high maintenance or otherwise. Thanks very much.
Are you introducing?
I'll now hand you over to the real expert and very exciting Conor Judge. Thanks.
Will you sit down? Yeah, thanks, Naomi.
Hi, good morning. My name is Conor Judge. I'm a nephrology consultant and general physician working in Galway University Hospital, and a clinician scientist working in the University of Galway. So I'm also going to talk about task shifting. So what we've heard from Naomi is task shifting between doctors and nurses. So this is known as task shifting type 2. A lot of the science around this comes from HIV literature. But there's 4 other types of task shifting. Task shifting type 0 from specialists to non-specialist doctors. Task shifting type 1 from doctors to non-physician clinicians that we've heard a lot about today. And task shifting type 2 that Naomi covered. Task shifting type 3 from nurses to nursing assistants. And then task shifting type 4, where you go from nursing assistants to the expert patient. So what I'm going to introduce today is something different. Instead of thinking of task shifting from one human to another, let's consider task shifting from a human to a machine, or a human to an algorithm, or human to artificial intelligence. So don't worry, you'll all still have jobs, but we'll just need to do things slightly differently. So let's introduce a new term. Let's call this call it complementary task shifting, and let's look at a concrete example. So if we think of task shifting 0 going from a specialist to a non-specialist, there's a company called iBrainomics that have generated an automated scoring system for CT scans for patients with acute stroke. So this is an example of a score that would have been only available from a specialist doctor, but where that task has been shifted to artificial intelligence to make that available to non-specialists. So the FDA updated their list of artificial intelligence and machine learning enabled medical devices last week. There's currently 178 devices that have been registered by the FDA. So they give a very detailed breakdown of all these and divide them into different categories. We're going to look at 2 of them now. So as we all imagine, the largest group is radiology. This takes up to 75% of the AI in medical devices approved by the FDA. The next largest group is cardiovascular at 11%, and then all the other groups in decreasing order are 3% or less. This really started to take off in 2015, and this paralleled improvements in deep learning architectures and also in the hardware, the graphics processing units involved in training these complex models. So I picked out some of the large names from the list. There's Medtronic, Philips, GE Healthcare, all of the international companies that we'd recognize. But this is also happening in Ireland. There's companies in Ireland, for example, X-Wave Technologies and Blue Drop Medical, that are also using AI to power their medical devices. So bringing the regulation a little bit closer to home, the first fully autonomous system to earn the CE mark for medical devices was approved back in April. So the name of the company was Oxypit. They developed an artificial intelligence model that was able to detect 75 different abnormalities on a chest X-ray. Now, they did something very clever here. They didn't compare themselves on those 75 to board certified radiologists, which would be a very high bar to meet. What they did is if there was none of those 75 things on the X-ray, the system from start to finish, from scan to report, was for normal scans, was all done by the AI system. If there was any abnormality found, then this was passed back to the human consultant radiologist. So this is an example of a smart AI-enabled decision triaging or triaging system, where the right patient is put in front of the right doctor at the right time. So if we think about the presentation we had from Naomi, where we're trying to focus instead from task shifting to task sharing, this is an example of task sharing between humans and artificial intelligence. So there's lots of challenges here. The European Parliament released a report back in June called Artificial Intelligence in Healthcare, and they highlighted 7 different challenges. The first was patient harm due to AI errors. So they used a very concrete example of where things can go wrong, models trained on one population and applied to another. The misuse of medical AI tools. So this is all about education of healthcare workers, but also education for the patients to explain to them what the involvement of the AI in their decision-making was. We've heard a lot about bias in artificial intelligence. Often, the data we use to train the models can contain bias. So we have to plan this from the very start. Lack of transparency. We often hear about the black box nature of deep neural networks. So one of the risks is a lack of explainability. So lots of work needs to be done on this. Privacy and security issues related to GDPR, gaps in accountability. If mistakes are made by the artificial intelligence, who's accountable for it? Is it the doctor that's sharing the task? Is it the payer? Or is it the company that designed the artificial intelligence? Finally, the obstacles in implementation are mostly technical challenges. Another major challenge is that artificial intelligence-enabled medical devices, we need to test them with the same scrutiny that we test medicinal products. They need to be tested with randomized controlled trial. These are results from a systematic review that was published in JAMA Networks a few months ago that showed only 41 trials, randomized controlled trials of AI-enabled medical devices all over the world. The largest group here was gastroenterology, so very different from the FDA list. Also, we need to think about education. So education of our medical students, of our nursing students, of our allied health students, medical education of our doctors, and re-education of our consultants. We need to be able to read papers related to machine learning and artificial intelligence. We need to question whether the model was generated correctly, whether it was applied in the correct population, and whether it was validated correctly. And as part of this, in the College of Medicine, Nursing and Health Science, we're developing a new master's in applied clinical data analytics. So this is going to start in September 2023. The aim here is to teach healthcare workers to code, to perform their own analysis, and to be able to critically appraise machine learning and artificial intelligence. One of the 6 core pillars of our program is machine learning. So we've designed an innovative spiral curriculum that's competency-based. So the same way that we learn medicine, we learn nursing, we learn allied health, we learn it by example. I just think, going back to what Michael Dowling said, this is akin to the plumber. You can read all about inserting the sink, but you need to insert the sink to learn it. So then it'll be a problem-based clinical research scenarios. So in closing, it's a very exciting time. This is just a small snapshot of what's happening. We have enormous opportunity. We train very high-quality healthcare workers. We also have the ecosystem for data analysis in the University of Galway. So now all we have to do is how do we integrate the artificial intelligence that won't compromise the core values, or as Michael Dowling said, the human factors, and ensure we retain our empathy, holistic and value-based medical care. Thank you.
Thank you very much, Dr. Conor Judge. Maybe before I let you go, just Conor gave us there a snapshot of what is happening. Naomi, I think I might come to yourself for a reaction about that. Do you seriously think we're going to be replaced by machines? Yes, the microphone there.
This wasn't in the contract, Martin, by the way, thanks. Do I think that...
That we'll be replaced by machines?
Absolutely no way, because patients want to have the human factor, and that's what we're all about. And all of these things, like I'm blown away by the stuff that Conor is talking about here. It's absolutely fascinating. But I suppose it's all about ensuring that the best care is given to the patient at the quickest time, because unfortunately we are really short-staffed, and these are really good solutions to big problems that we have. So it's not a replacement at all, but it's I suppose a wonderful welcome addition. So.
And Naomi, what do you think is going to be the next big change now for nurses?
Ooh, well, nursing is adapting all the time. I think that's one, like the nurse is always the centre pin of everything that goes on. Yeah. Everybody comes to the nurse, to find out what's going on. And I think we are ever adapting, which is great. There are these advanced roles. I think there will be more advanced nurse practitioner roles, hopefully in the community, like we were talking about earlier, will definitely. And it is a great way to keep nurses in the career, because traditionally, if you went into nursing, you either went up and became a manager, or you left, maybe went into education. Now, excuse me, we're seeing a collaboration of the two together. We're seeing a collaboration of the clinical setting and the education setting. So it's brilliant. That's been more in medicine for years. I think doctors were much better at keeping both strands going. And now nursing, I think we're coming alongside as well, to keep the academic and the clinical side going together, which I think will definitely keep more nurses in the profession as well.
Brilliant. Naomi Davies, Dr. Conor Judge, thank you both very, very much for that. Now, our next topic is one that we kind of touched on earlier. It's integrated care, a new setting for the future delivery of healthcare. Basically, how we can better care for patients in their own areas, not in the hospitals. So, integrated care is one of the HSE's most significant programs. Integrated care aims to join up health and social care services, improving quality and putting patient outcomes and experiences at the centre of everything we do. It means changing the way care is provided so that people with complex needs can live healthier and more independent lives. Now, we're joined now, thank you very much, by Professor Martin O'Halloran, Techrit Professor of Medical Electronics, University of Galway, Professor Michelle Canavan, Consultant Geriatrician with Saolta University Healthcare Group, and Ciara Breen, Occupational Therapy Manager with the HSE. Thank you. I'll introduce the panel to you first, and then a little bit more, and then we'll open it to the audience, okay? Professor Martin O'Halloran, first of all, he's the university's first ever academic appointment to span the colleges of medicine and science and engineering in 2015. He is the executive director of the BioInnovate program and co-lead of the Health Innovation Hub program in Galway. He's a 6-time recipient of funding from the European Research Council, and he is named inventor on 27 medical device patents and was co-founder of Luminate Medical, a Y Combinator funded company. Now, Professor Michelle Canavan, Consultant Geriatrician with Saolta University Healthcare Group, you are perfect. I'm only getting to know you now, thanks a million. She is Consultant Geriatrician and Clinical Lead for Galway Integrated Care Programme for Older Persons. Michelle has developed orthogeriatric service at UHG in conjunction with the National Hip Fracture Database. Professor Canavan is the newly appointed Established Professor of Older Adult Health and Consultant Geriatrician at the University of Galway. And Ciara Breen is occupational therapist of over 20 years experience, the majority of which clinically has been in stroke, older persons and neuro-rehabilitation in both Ireland and Australia. She's been OT manager in Galway University Hospital since 2017, but she's imminently taken up a national role as HSCP lead in the National Clinical Programme for Stroke. She is also HSCP lead to the National Working Group on Long COVID. Thank you all very much for joining me. I'm going to keep the iPad with me just in case you want to fire a question here into the iPad, and I'll join you over here. Michelle, maybe to yourself first of all. Breda Crehan-Roach mentioned there earlier on, she mentioned integrated care. Can you describe integrated care and what's happening in the region, and how does it all fit into the national context?
Yeah, is this working? Yeah, okay. So thanks very much for the opportunity to talk. So I've been involved in developing integrated care over the last 3 years here in Galway. And that came from, I think Michael Dowling referenced there, you know, being innovative and looking for other solutions outside of how we normally do things. We had an A&P in Loughrea where, you know, we decided, well, could we offer a clinic out there instead of people coming into Galway? And that was the kernel of the development of integrated care here, where we developed a kind of a pilot program. We started seeing people in primary care, actually. We were going out there rather than patients coming into the hospital. And I suppose that's it. It's a simple model. Patients want to have care close to their home. They want to get the specialist care that they should get. But, you know, they don't necessarily want to come in. One of the biggest feedbacks we got was trying not to find parking in Galway University Hospital. Like when they can go to their local areas, it's much easier for them. But yes, it's important for us to provide the right people to deliver that care. So having the multidisciplinary team, you know, working with advanced nurse practitioners and having that available to people in their community in conjunction with the primary care teams that are already there. And I mean, I think we've talked a lot about integration here. Integration is a difficult piece because we've all worked in our siloed traditional ways. You know, I trained in the hospital. Nobody trained me in integrated care, but you know, this is the way it's going, and this is how we have to move forward. And I think there's just huge opportunities to develop that further. And we have been thankfully funded through the National Older Persons Programme, along with ECC programs, to deliver that kind of care in the West region. And we look forward to developing that further.
Thanks. Michelle, actually, and Ciara, were you going to have a presentation at the start?
Yeah.
You were, weren't you? I have jumped too far ahead with my panel discussion. Sorry, guys. Would you mind taking to the podium then and doing the presentation first of all? And excuse me, I was ahead of myself. So I'll let you do the presentation first of all. Thank you very much. My apologies.
Future that starts here.
So just going to talk a little bit about myself and Ciara both going to just talk about our experience of integrated care and how we feel it's such a good setting to actually, you know, to be the future of healthcare, and also what we need to do to enable our workforce to be appropriately trained to be able to deliver this care. I do have my geriatrician hat on, so I'll probably focus on older people a lot, but I think, you know, as we've mentioned, you know, this is the future in terms of the ageing demographic and how we actually provide care to these patients. Is that moving? Sorry. So we are in the decade of healthy ageing. This is designated by the UN, and this is underpinned by a vision of older people living longer, healthier lives, independent and at home. And I suppose, you know, when we think about the why, this is why, you know, how we need to be planning our healthcare. You know, we need to be able to provide end-to-end clinical integrated care. We need to do that, and we need to provide that by healthcare professionals that are trained to work in an interprofessional manner, because it's not just about the doctor, it's not just about the nurse, it's about how we all work together and how this complex health ecosystem actually works together. And I think we need to, you know, push the boundaries a little bit and think outside of our traditional system, and how do we manage to do that to provide the care that's important to older people particularly, but to all healthcare users, and develop sustainable services. So here in the West, we do have quite a frail older population, and that is increasing. You can see from the graph there on the right. And we have unique challenges here. You know, we have, I was touched by what Michael said about, you know, what works in Dublin doesn't work in the West, and that's true. You know, we have geographical challenges, we have health equity challenges, people have been able to access health, and that's something that I suppose is also an opportunity. And I think in terms of retention of our healthcare professionals to be able to deliver that care, we need to think about how do we attract them to the University of Galway, I suppose, to do their undergraduate careers, how do we promote their postgraduate careers, and how do we, you know, encourage them to stay here and work here and to deliver that healthcare for the people of the West. We've mentioned a lot about the changing interface of healthcare, and this is true. We have the regional health authorities coming, and I think, you know, as Tony and Breda mentioned, this is a huge opportunity for us to actually shape what we want for the patients of our region and what their specific healthcare needs are. And you know, this has to be driven by patient engagement and patients telling us what they want and what they need, and then we build a system around that, not just what's convenient for me to run a clinic in the university hospital rather than going out to Tuam or Loughrea or wherever the case may be. I think how we and where we train our health professionals is hugely important. The role of interprofessional learning. Integrated care is actually a great space, I think, to reinvent that whole idea of interprofessional learning and how we do that, particularly with the advent of the ECC programs where we have chronic disease management and diabetes, heart failure, COPD, and respiratory problems, along with older persons who have a bit of everything. And we need to be able to work in that way. We're not often trained that way in university. You know, we work in our little silos. There's elements of it within each course, of course, but I think we need to maybe have a bit of more focus on bringing that into the curriculum at an early stage and also right through the postgraduate course. And lastly, and I know Martin will touch on this, how we use research and technology to improve care for older people. You know, we learned during COVID, you know, telehealth, older people have become a lot more familiar with technology, and their carers certainly are. We're able to facilitate a lot of things using technology to enable patient-centred care and devices to help people stay independent at home, but also how we use technology to educate. You know, we do a lot of regional education around with our academies, and there's been a huge amount of work in simulation, and integrated care is a great area to do simulated learning in an interprofessional way. So this, I won't go through it all, but it was one of the future visions. We came up with the National Programme for Integrated Care about what is our vision for older people here in Galway, and it's complex, and every arrow on that diagram really represents a patient or a carer's interaction with us as healthcare professionals, with their GP, with the consultants, with the hospital, and we just really need to think about how we build that interdisciplinary working, because it is complex. You know, we talk a lot about integration. The integration is the hard bit, because we're all used to working in a certain way, and that's what we need to change, and I think that's what we need to have coming through in our healthcare programs at the university. So we've mentioned before what works. You know, the optimal model of care, particularly for older adults, is care close to home, care that's coordinated, that they can actually access. You know, having somebody to call when you're in crisis and being able to get the cascade of all the healthcare going at that stage. Alternatives to hospital admission and healthy ageing and health promotion have to be the core of what are we trying to achieve here. It's coming. So this is the older person's chronic disease model, and you know, Michael Dowling mentioned how, you know, it's not hospital centric anymore. We spend so much time and money up in the right hand part of this diagram, but we actually need to think about how we shift that to the left, and how we develop this integrated healthcare that's responsive. And it's not just one or the other, it's actually a whole spectrum of care that people will travel in between various aspects of it as and when they need to. And you know, the collaboration with our GP colleagues has been huge for us in integrated care, where we can, you know, be in the primary health care centres, and it develops all other kinds of relationships now. We're involved in primary care team meetings, you know, all the learning that comes from working together. And you know, some of the programs, Michael Dowling mentioned a lot about the ambulatory programs, and this is certainly, and Ciara will touch on this as well, the importance of reablement for people at home in their own homes. It works much better than them going to a rehab setting if appropriate. Early supported discharge following stroke, and then the benefit of integrated care teams and appropriate step-down facilities where people can actually get rehab, get back on their feet, and then get home. But we need to look at this in a different way in how we provide it. And just to mention, I was starting there in the talk around how we developed this kind of hub and spoke model for care. You know, we talk about the challenges of accommodation and finding space to see patients, which a lot of doctors coming into new consultant roles have that challenge. I didn't have much clinic space. We got an opportunity to maybe work with one of the advanced nurse practitioners out in the community. And we said, well, why don't we start up a clinic here? We worked with the local GPs. We got them on board, and we kind of rolled that model out in Tuam area. Now we have a new colleague started. We're going to roll it out in the West Galway area, because you know everyone coming into the university hospital doesn't always work. So it's been a very successful model. We got funded by FutureCare for the pilot, and then it was thankfully brought into the ECC funding. We've taken 700 outpatient appointments out of UHG since we started, and we're heading for over 2,000 attendances between the Galway West and East teams this year. And I suppose we just wanted to branch that model out. You know, I'm just talking about Roscommon, Galway, that's what I've been involved with, but also we've the same thing happening up in Mayo. And it is, you know, the strength of this has been the development of relationships between ourselves and Community Healthcare West. Because as Michael said, it's not just the medical piece, it's the whole other social care piece that goes along with minding these patients. And that is the essence of integration, I think, you know, this cross-organisational collaboration. And I just put up a few quotes because I think, you know, that's exactly what we're trying to say here. People find things convenient, and they find they're being listened to, and that patient voice is so important. You know, we need to listen to them in terms of what they want for their care in their later years, and how we best provide that. And I'm going to bring Ciara in here to finish off.
Thanks, Michelle. So I'm going to talk you through another example of how this looks in practice. So how does integrated care come down from those principles of integrated care, and what does it actually look like at the level of patient interaction? And one example of what it looks like is this sort of team, which is an older person's rehabilitation at home team, which delivers rehabilitation care directly in the person's home by a highly skilled multidisciplinary team. Now, this is a very successful team, but that's not what we're here today to tell you. It does save lots of bed days, and it's very suitable for the organisation. But really, the essence of it is how do we scale up these sorts of teams so that we have teams who are able to leave the safety blanket and the security of what we know. We know that moving left is a change, and we have to attract people to jobs that look that way, that by selling these sorts of models and by really showcasing how they can work for patients as well. More than with Michelle's quotes, the satisfaction with moving rehabilitation to people's homes is really evident across the board, and evident in our team, evident across the country with regards to ESD and stroke teams, and internationally evident as well. Patients want to be in their own home. Never mind the Michelin chefs, they want to be in their own kitchen eating the comfort food that they want. They want to be sleeping in their own beds. They want to be petting their own dog, maybe. So, do you know, part of it is about the best place for people to recover from the very, very acute piece that needs to be in hospital is then often in their own homes. However, to deliver that, we need to work in different ways. Oops, sorry. Sorry, I thought I'd gone backwards there. I've gone forwards, which is always good. So how do we train the healthcare professionals to deliver this care? This involves, you know, really development at undergraduate level, as Michelle referred to. It won't happen downstream unless we create it upstream. And that means that we need to plan at higher levels, you know, of education to create opportunities for students, undergrads and postgraduates to learn, because there's also a lot of us still knocking around the health system with the old ways, and we also need to be upskilled and also need to be challenged and showcased how to create new ways of working. So we need to do that, and then within our institutions we also need to meaningfully value integrated care as well. If we don't plan in a multidisciplinary way, it won't happen at the level of the patient either. And so really it's like a stick of rock where every time you slice through, it should be integrated. And if there's a gap in that connection, it really won't happen in a meaningful way at the level of the patient. So we need to recruit and retain skilled workforces. And I can tell you that when it works, it is a magnet. It does work. The Oprah service is one of the shining lights in our occupational therapy team, in our older person service. Same for ESD stroke, same for ICPOP. These are services that people do want to work in because they can genuinely see the impact at the level of the patient. That's why most people go into healthcare. There's also a role for digital health and technology within this. Thinking about dispersed teams working within a community setting, often working at different times of the day, of the week, with the same client. How do they come together to create a meaningful wraparound level of care for that patient? It involves things like digital notes. It involves, access to the various different strands of care that are needed. And it also means maintaining connections in all directions. So maintaining connections across the diagram that Michelle presented, maintaining connections back to the consultant if that's needed for an acute or a concern that's needed. Equally, maintaining the same levels of connection with the home help that's working with that patient and will be for the next 4 years. We also need that academic leadership and mentoring, and most of all, we need that culture change. We need the embracing of these new ways of working. These are not add-ons. This is a radical shift, and this is what we need to kind of embrace and take on if we're to make it work for us in this region. So in terms of planning for integrated healthcare, we've spoken already this morning about training, attracting and retaining skilled healthcare professionals. This is and can be a really, really positive way of working. This is what we want. It's demystifying some of that by really talking about the good work that is occurring in small teams and pockets and really scaling up what can be scaled up. A lot of this is about feet on the beat and really actually the potential for scaling. All of these, it's a simple idea, but when done well, it can really have a meaningful impact. The digital health technology that obviously Conor Judge has referred to in a lot more detail this morning are huge enablers for this type of work. And then driving clinical excellence through impactful research and policy development. So funding needs to follow this as well, and also leaders need to come out of this as well. So it's not just about having teams on the ground that are following a recipe book. This is about actually leaders coming through, like Michelle Canavan, in terms of integrated care, and actually really, seeing that being voiced and communicated throughout our health service. All of this is going to lead to one of the answers to the challenge of living well in a healthy aging way at a population level for the region. Thank you very much.
Thank you. Thanks very much, Claire Breen and Michelle Canavan. That was brilliant, and I'm really sorry that I jumped ahead there earlier on. We'll welcome any questions now from the floor about this particular topic as well, but Martin, maybe I might bring you in as well now, since Ciara kind of touched on it there about the digital solutions, but are there any strong examples of digital health solutions in medtech that are already delivering benefits for patients?
Yeah, I think there's some ones I think are really inspiring. So there's technologies that's been developed in the last, I think, 5 years for heart failure patients. And where this came from is in the US, they did an analysis of the number of heart failure patients that were readmitted into hospital. And each readmission was costing something like $17,000. So they said, a lot of the reason for readmission is just unoptimized medication. So a couple of companies now have developed technologies where you can monitor continuously the blood pressure of patients. And so that allows, if a heart failure patient is discharged, their blood pressure starts to increase, the clinician gets alerted and they can modify their medication. And so they never end up back in A&E. And I thought that was really interesting. I was talking to a clinician in Ireland who's involved in that trial, and I said, what impact is it having on you? And he goes, I just don't see these patients in A&E. Yeah. So they're staying at home, the acute event doesn't happen. So I think that's really inspiring. I think the challenge with it is that where medtech as an industry is innovating is in areas of very significant cost. So you can do that in heart failure because of the costs associated with heart failure. I think in more rare diseases or more rare conditions, the economics are more problematic. And so I think it's thinking smarter in areas like that.
Very interesting. And in the whole area of communication as well, for example, if there's a patient, for example, in Leenane in County Galway, public health nurses going out to him, maybe different services. But is there a lack of communication? Is it difficult to kind of keep track of the progress of this patient, for example? We don't probably have the communication system to do it, do we?
So I'm going to pass over that question, but just to say, I think...
Or could it be developed?
I think it's a really good point. So it's often it's not a technology problem; it's an integration problem. So we have the solutions, we have the technology. So I'm saying this as a technology person, but the technology exists and it's in other sectors. But it's how do we integrate that into the health service?
Is it there already, Ciara?
I think there's some elements that are there in part, I think there's definitely a lot that's happening in terms of that communication piece. Certainly for us, a huge advantage has been moving to electronic healthcare records, because it means that when the person's in the home, they can actually, check in, see what's going on, be up to date with the clinic appointment that maybe happened yesterday. So those are huge enablers. It sounds, really simple, but also that stops then when you go outside of the hospital network. So it's a different system then for some in terms of community. Yes. So for example, you may be on different systems, not everybody has the same access, and obviously GDPR issues and things like that are very relevant concerns, but there's sometimes we need to think disruptively about how we can create those pathways and connectivity, I think, between it, because there are the opportunities there to resolve those issues.
Oh yeah, big time. Yeah, Michelle.
Just to echo exactly what Ciara and Martin have said, but I see patients in clinic if I'm out in Portiuncula or Loughrea, and they say to me, well, why can't you see what happened to me in Portiuncula, because I only have access to the Galway system. There's a 90-year-old patient in a clinic in East Galway, so they see it, and they think we can actually see all their data, but yet we get hung up in the bureaucracy around GDPR and all that, and I'm not saying that's not important, but I think we need to find innovative ways around how do we do that, and how do we be able to share this information, because so much of it is sharing, and equally our GP colleagues, like they can't see investigations that were done in the hospital that could be really relevant when someone comes in with a particular complaint. So, joining that up together and having all these systems is huge, and I think the opportunity for partnership within the university here because these guys have all these, they have a lot of these solutions, and how do we harness that into the healthcare setting?
Yeah. Brilliant. We have a question here from the floor as well, just this gentleman down here. Your name, please. Tomas. One second, I'll get the microphone to you. Thank you.
Thank you. I have a question for Michelle and Ciara. Thank you very much for the lovely talks. Have you any experience of integrating the integrated care hubs? So you mentioned that. Michelle, you said that, correctly, that people with attending yourselves have little bits and pieces going on, and often diabetes is one of those. And have you any experience of integrating the older adults care hub with the diabetes care hub or the COPD or heart failure care hubs? And what's your thoughts on that?
So I'll start with that, Ciara, because these hubs, although they're on the diagram, haven't actually materialized yet. So the physical integration is not happening yet, but it is a vision, and I think that idea of a place in the community where people can go for ambulatory care, and you have the presence of the diabetes team, the heart failure team, the older person's team, to be able to work together and cut down and actually create that whole integrated care pathway for the patient. So to answer your question, we do it in pockets, where we can at the moment, but because we're not all located together, but we still work together. But again, it comes through to the ICT part of how we connect. Even if we can't connect in physical buildings, like how can we connect virtually? I think there's a big role for maybe interdisciplinary meetings among the various specialties, located in these hubs, and that will all come. That's all part of the plan. But I think it's in its early stages, and that's not how we always did things. Comes up a lot, and I think that's one of the biggest challenges that all of us have to kind of face and try and work through, because we just need to change how we think about how we deliver this care.
Yeah, mine is, I think integrated care is, we're carving out new space, aren't we, really? So I think the best integrated care doesn't have a shape in a way. We have to create the boundaries that form the shape of the integrated care. And I think we can choose to create very constrained and tight boundaries, or we can choose to create more fluid ones. So I think as the walls come down a little bit between the different services, I think there'll be a lot more choosing to connect. And I think that it's that interoperability between services that will be critical to success going forward.
And Michelle, of course, this was going to be a major shift, this integrated care, but do the undergraduate and postgraduate programs, do they reflect that?
I think certainly within every programme, this ethos of care is definitely reflected, you know, and that's, as Ciara said, that's why we all become healthcare professionals, you know, to deliver this care. And it's not just the type of care I can deliver, it's how the impact of the whole spectrum of care impacts on the patient. But I think there certainly is a role for maybe embedding more interprofessional learning within the undergraduate curriculums right across the College of Medicine, Nursing and Health Sciences, but also maybe to develop those postgraduate programmes that Ciara talked about, you know, that focus on actually, you know, we have skilled healthcare professionals already working in our system. How do we equip those to do that integration that the most talked about? How do we integrate the integrated care? But people need to learn those skills, and I think the university has a lot to offer there. So I think there's definitely room for development of that whole programme, both throughout the undergraduate and postgraduate curriculum.
And maybe just Martin, just maybe to finish it off, I suppose, unless there's any other question, but I suppose, you know, on a positive note, there are like lots of medical technologies coming on stream, aren't there, that's going to make this much easier in the future.
Yeah, and I think the panel has touched on some interesting points in that the bar is actually so low. Yeah. You know, if we move, like we obviously work as an engineering, we work across sectors, and you see in the automotive sector or in the mobile device sector how fast things move, and then like I work, my lab is in the hospital, so you pass by these patients and you see just the lack of technology and the lack of good solutions. So I think these kind of cross-disciplinary discussions and letting engineers and scientists see the problem and help develop those solutions. But I think the thing that always surprised me is that the bar is so low. There's so many areas that we can improve quite quickly and quite simply. Yeah,
when you see what could be done during COVID and how fast we were able to move, like it would really kind of give you some hope for the future. I'll leave it there. Martin O'Halloran, Ciara Breen, and Michelle, do you want
I know Martin probably had a few examples in his presentation.
You maybe do. Oh, did you have a presentation?
No, I think we've covered. I suppose my point in the presentation was that, and I think we've talked about it here, is really just that those solutions exist. So it's not, I think, and I'm putting my hand up saying, I'm saying this as an engineer, the problem is not an engineering problem. It's engineering, understanding the complexity of the health service. And so I think, I suppose a lot of the collaboration that's happening now between the College of Medicine, Nursing and Health Sciences and Science and Engineering is really positive. We're bringing together those groups to find those innovative solutions. So I think some of the challenges in digital health at the moment is just people without the medical knowledge developing solutions in silos. I think that's not helpful. But I think some of the projects that are ongoing in the university and the hospital are really promising.
Martin, thank you very much. Thank you. Martin O'Halloran, Ciara Breen and Michelle Canavan. Now, Chorza, we're joined now by Honorary Professor Derek Stewart, OBE. He's going to be moved out because I think everyone's getting hungry. Oh, okay. I think that's a great idea, Michelle. Like, until the afternoon. Okay, well listen, we're all going to take a break then. Lunch. So lunch, 20 minutes for everybody. Thank you very much.